So one of the things I want to talk to you about today is my experience with managing filler-related issues around the under eyes in patients that ultimately need a blepharoplasty. I'd say about 30% of my practice, or a third of my practice, are patients that have had prior lower lid fillers. They've had prior lower lid fillers in the past. Most of the time, it's done well, done great. But with time, with years has gone by, these patients have developed just an ongoing prominence in their lower lid fat. Fillers won't help, and their injector doctor has basically told them you now need a blepharoplasty. This is a very common presentation in my practice. When I see these patients, most of them do quite well with my standard algorithm, which is essentially to dissolve the filler starting about a month before the surgery. I use hyaluronidase. It's an enzyme that breaks hyaluronic acid into water. And my philosophy is I dissolve as much, if not all, the filler prior to surgery. Fillers can absorb fluid. Fillers can create prolonged swelling after surgery. And fillers can also result in an unpredictable result for me because I'm using the patient's anatomy to identify how hollow they are, how much fat I need to reposition in that area. If there's filler present, that throws me off. I'm not able to get the right results. And on top of the other issues that can happen when filler's in place in the time of post-operative recovery. So I like to dissolve the filler. And my philosophy in dissolving fillers is take it slow and steady. So I don't like to dissolve all the filler at once. One, the patient will not quite like that and not used to seeing their face without filler. But two, I want that skin to contract during that month to kind of rehabilitate so they can be optimized for surgery. Oftentimes, I will treat the skin with either a CO2 fractionated laser, microneedling, chemical peel, or in really severe cases of a skin excess, I'll do a skin pinch. But I want that skin to retract with time and kind of contract. So I do partial dissolution of the filler, and I do it every 2 weeks, spaced apart, starting a month before the surgery. I generally do about 1 or 2 treatments in my patients. I started seeing patients that had filler-related issues and needed a blepharoplasty. What do I mean by filler-related issues? Well, they had chronic swelling, edema in the malar area, number one. They had visible product. The product was visible. You can see it as a blue-gray color. It's called a blue-gray dyschromia, also termed a Tyndall effect. You can actually, in some of these patients, see the product. You can see a little bit of a lump. You can see a little bit of a bump, and they're unhappy with that, in addition to having fat prolapse. So these patients are in a different category, and how I describe them as those that have filler-related issues that need to be resolved prior to surgery. In my practice, I want that edema to be resolved as much as possible before surgery. I want that filler to be dissolved as much as possible before the procedure. I want those lumps and bumps to be gone, so they will still undergo the same treatment of anyone else that has had under eye fillers prior to surgery. And I'm careful in making sure that those visible bumps are gone, the blue-gray dyschromia or the Tyndall effect is resolved. I want to make sure that malar edema is improved as much as possible. So the question is, how do these patients do after surgery? In my publication, that presented to me with filler-related issues, and they all needed eyelid surgery. So I follow them before surgery and after to see how they did. The good news is that overwhelming majority of them did just fine. But I'd say 20% of the patients in that series had prolonged swelling that actually lasted for up to 6 months. So it's very important for my patients that have already onset edema before surgery. I'm obviously trying to reduce that edema as much as possible, but if that edema is still there, thankfully, that edema doesn't normally get worse after surgery, but it can often persist. So that's a nice discussion to have with patients. My goal is to make sure that edema is gone as much as possible and all that filler is gone. And despite dissolving as much as we possibly can in these patients, despite doing the surgery the right way, these 20% of these patients in my study still had swelling longer than expected. I'd say most of my patients' swelling resolves within the first 6 weeks to 3 months. Most of them around the 6 weeks period, you'll notice almost a 90% improvement. By 3 months, they should be pretty much resolved. Patients that have had filler-related issues, that swelling can persist up to 6 months, but thankfully, majority of those 20% patients, that swelling resolved by around 6 months. So it's a prolonged recovery because of the filler-related issues they have. The reason we're not entirely sure is probably that it just takes a little bit longer for the body to absorb your own fluid. Fillers can sometimes obstruct some of the plumbing, the lymphatics that drain the fluid. So there's all these theories about that. But ultimately, there's recovery in most patients, just takes a bit longer, and it's a matter of letting patients know. So would I still operate on somebody that has filler-related issues? Absolutely. But I really prefer those patients that don't have edema present. Having edema present, swelling, fluid in the malar edema in the malar area will potentially stay. It's rare to get better. And oftentimes patients need to know that if I'm reducing the fat prolapse here, that swelling is still present. They need to be okay with that. They need to be on board with me. Acceptance of what we're doing here to make sure we get the best result as much as possible. So take home points from that publication is that there's more and more people that are undergoing under eye fillers. The most important thing is, as a patient, if you're getting under eye fillers, make sure it's done by an expert, somebody that has incredible, adequate training to perform these fillers, understands when you're not a candidate, understands that you're a candidate versus a surgery candidate, and also undergoing a safe treatment, that one that uses minimal filler, that's not excessive, that allows for you to have a good natural result. And so that's the take-home message, point number one. Two is, if you've had prior fillers and now you need a lower lid blepharoplasty, you're probably going to do just fine. I just want you to know that there's, statistics from my data and what I see. In my patients, you'll do just fine. It's the patients that have the visible fillers prior to surgery, that have chronic swelling before surgery. Those patients are the ones that I have a more high alert for, and I may not recommend surgery if that swelling in the malar area, for instance, is more significant than I'd like, because the results from the surgery itself will not be that obvious. Even though the fat pockets are improved, that swelling there is still an issue. So that's a challenge in my practice. Laser treatments, RF microneedling can possibly help, time can help, but that's the challenge when it comes to that particular area. Again, it's about talking to patients, getting to know what their demands and goals are, and seeing if my work can help get them to a better place.